Hello and namaste. Today we will be discussing about urinary tract infection in children. It is a very common infection we encounter in our day-to-day practice. Um, the overview of today's presentation is we will cover about the definition, epidemiology, and pathogenesis, as well as clinical features and classification. Similarly, like we will focus on how can we make the diagnosis of UTI, and we'll broadly see the management as well as the follow-up of UTI cases. So we'll begin with this case. There's a 6-month male who presented to emergency or OPD with a history of a refusal of fits, irritability, and fever for 5 days duration, along with many written investigations. Urine examinations were done, which was suggestive of urine REME of 5 to 6 WBC per high powerful. Urine culture was sensitive and it was in significant colony. So the physician decided that we should give antibiotic. So cefixime was given, which was given for 7 days. It was given on OPD basis, and the child was not followed up. So this is just a 6-month child with UTI. Obviously, this is not an appropriate management for this child. The child should have undergone further investigations. As we proceed with our presentation, we will be knowing that what are the important investigations that are needed to be done in such cases. So first, what is the diagnosis of UTI? Like, why is the diagnosis of UTI very important in children? Because it brings us attention to a child with an obstructive anomaly or severe vesico-urinary reflux. We may not be knowing that okay, the child has any obstructive problem or VUR, and they present with UTI. UTI is a risk factor for acute kidney injury, and we should be very careful for that. There are long-term complications of UTI like renal scarring, hypertension, and even if not dealt properly, they may land in chronic renal failure. That's why it is very important when we are making a diagnosis of UTI to work the child properly. So epidemiology of UTI, it's the third most common bacterial infection in children. Symptomatic UTI below 14 years occur in about quite significant proportion of children, like it happens in 1 to 2% of boys and 3 to 8% of girls. Urinary tract abnormalities in evaluated UTI. So I would just like to stress upon the word evaluated UTI. So UTI should be properly evaluated, and it is seen that urinary tract abnormalities is present in about 30 to 40% of the cases. If we investigate the UTI properly, it has been seen that obstructive malformations like posterior urethral valve or bladder outlet obstructions has been seen in about 10% of boys and about 2% of girls. And similarly, vesico-ureteric refluxes has been observed in about 24% of boys and 36% of girls. So next is the definition of UTI. So how will you define UTI? It's a growth of a significant number of organisms of a single species in the urine and presence of symptoms. So these three things: significant number of organism in a single species. So a single organism should be present, and it should be present in significant amount, and there must be presentation of symptoms. So all these three should be present to label it as UTI. So what is actually the significant number of organisms, which we call it as significant bacteria? Suppose we have done a suprapubic collection of urine. If any significant colony count is there, we will say that okay, fine, this is a UTI. However, if we do a catheterization, a presence of about more than 5 into 10 power 4 colony forming unit will be label it as a significant bacteria. And commonly routinely practiced is midstream clean glass urine. So if a coloniform unit count is more than 10 to the power 5, then we can say that 95% of the chances that it is UTI. So significant bacteria remains the very important component, and we will next be dealing with the etiopathogenesis. So in girls, the most common cause, about 90% of the condition, it's E. coli, followed by Klebsiella and Proteus, which causes UTI. In boys more than 1 year, almost equal amount of E. coli and Proteus are the causative organism. Others like Staphylococcus, Saprophyticus and Enterococcus are also common, and sometimes adenoviruses 11, 21 can cause UTI. So how do we acquire urinary tract infection? Mostly the urinary tract infection is an ascending infection for all the ages. Actually, it's from the perineal surfaces to the urethra and then to bladder, ureter, and later on, if not treated or not evaluated properly, can cause pyelonephritis. In neonates, however, and in some conditions like infective endocarditis, the kidney may be infected from the blood. If there is septicemia, like neonal sepsis, they can develop pyelonephritis. So next is the clinical feature of UTI. So it varies, like there may be different clinical feature in neonates and in younger children as well as older children. Like in neonates, there is no classical features of UTI. It mimics like any infection. So the child will be lethargic, won't feed properly. There may be neonatal jaundice. So case of neonatal jaundice often requires evaluation for urine. Similarly, there can be hypothermia or hyperthermia, and there will be other features of septicemia too. Whereas in infants, the fever will be unexplained, and there can be persistent diarrhea and vomitings. Whereas in older children, we may get a classical history of burning micturition, crying during micturition, increased frequency of micturition, fever, flank pain, urgency, frequency. So these are classical features which can be seen in older children. So by evaluating the clinical feature, we can say that is it a simple UTI or a complicated UTI. In simple UTI, we are going to have a low-grade fever. Child will be just febrile, and there can be a feature of dysuria, frequency, and urgency. Whereas in complicated UTI, it will be of high temperature, fever of more than 39 degrees centigrade. There will be systemic toxicity. Child will be vomiting, there will be dehydration, you may get a renal angle tenderness, and the renal function test may be deranged. Now, what are the important clinical findings to look for in cases of suspected UTI? The first thing is like we need to have an antenatal scan if it is present, to see for antenatal hydronephrosis, to evaluate for the how much quantity of liquor was present, amniotic fluid level. Those all give some hints towards any congenital anomalies of urinary tract. Similarly, we should take the history of constipation. We should ask them if the child is suffering from constipation or has difficulty in passing stool. And how is the urinary stream? Is it appropriate, or is there dribbling of urine present? Does the child needs to go, basically preschool child, do they require going to bathroom or restroom quite frequently? Is there any episodes of urgency or frequency? And was there any anomalies present, like sacrococcygeal teratoma or spina bifida, or any spinal cord defects was present or not at the time of birth? These are very important things to be asked, to be looked for. Similarly, we have to examine the genitalia properly. In female, labial adhesion are quite common, and this can cause recurrent UTI. In male, however, phimosis is very important findings which we have been seeing and observing in our day-to-day practices. If it is present, again it is one of the risk factor for urinary tract infection. Spinal dysraphism is important to see and observe, and if there is any patulous annus or not, that should be noted too. Holding maneuvers like crossing of legs to hold the urine, pinching of the shaft of the penis or tip of the penis to hold the urine, holding the urine in squatting positions. These are all suggestive of some form of bladder bowel dysfunctions. If suppose the child is passing very frequently urine, sometimes parents come to us saying that my kid needs to go to void almost every 15 to 20 minutes. So again, that is suggestive of some form of bladder bowel dysfunction. Some may, however, not pass urine 3 times in 24 hours or 12 hours, say. Then again, that is the thing that needs to be evaluated properly. The child may have a bladder bowel dysfunction, and it is one of the predisposing factor for urinary tract infection. So all this history are very important. So whenever a child comes to you, I hope that next time we have to see in all these clinical features properly, which we tend to miss actually. Now, how will we investigate a case of UTI? So straightforward, urinary analysis should be done. It consists of urine routine microscopy and urine culture. A point of care test, that is urinary dipstick test, is of very significance, holds a significance value if it is present. Ultrasound kidney ureter, KUB is kidney, ureter and bladder is very important. And in indicated cases, micturating cystourethropography MCUZ and DMSA scan should also be done. We'll see in which cases what should be done. So urinary evaluation by doing urine routine microscopy is a very easy and very effective way to analyze for UTI. By doing this simple test, we can see if bacteria are present or not. We can see for white blood cells, if it is more than 5, more than or equal to 5, high powerful, we label it as leukocyturia, a significant, and it holds a significant value. Similarly, if WBC cast is present, WBC cast is in urine, it is suggestive of pyelonephritis. Now, this urine dipstick is a point of care test. Basically, we have a dipstick, like we have a stick, we dip in the urine, and maybe after 2 or 3 minutes we look for the change in color of basically nitrates and leukocytes. So by doing a leukocyte esterase test and nitrate test, and by combining it with microscopy, like we can get a sensitivity and good amount of sensitivity and specificity. So by far we see nitrate test has a very high specificity, 98% of the cases, with E. coli, basically nitrate reducing bacterial infection. We'll have a nitrate test positive. Similarly, if we combine to get a high sensitivity, if we do a nitrate test or microscopic or a leukocyte esterase test, if either of the tests is positive and we need to screen further, like they can have a sensitivity of about 100%. So this is like how to collect the urine for culture. This is again a very important step which is often ignored in day-to-day practice. So we should be very specific. Like it is important that we wash the genitalia with soap water, collect the midstream clean cast urine in a sterile container. So midstream means like when the child starts voiding, you should collect the middle portion of the urine in a container. Basically, we get for urine culture sensitivity. Then immediately after that, we have to cover the lid, and it should be promptly processed within 1 hour. Again, that 1 hour time frame is very important. If suppose it is going to take a long time, we have to store the urine sample for 4 degrees centigrade for 12 to 24 hours in 4 degrees centigrade. In neonates and infant, the best way of urine collection is per urethral catheterization or suprapubic aspiration, because it is difficult to collect by clean cast midstream urine sample. And the important no is like not recommended is collecting through bag. Like there are collection bags, combi bags which are available, and I have seen many a times like we collect the sample from those combi bag, and that is not recommended at all. It doesn't hold any value to label a UTI. So okay, for criteria for UTI, like if we have done a suprapubic aspiration and if we are getting any single pathogen, urinary pathogen, it should be labeled it as a UTI. If we are doing urethral catheterization, 5 into 10 power 4 colony forming unit must be present to label it as UTI. If it is less than that, we should not label it as a UTI. And for clean cast midstream urine, so it's more than or equal to 10 to the power 5. That number of colony forming units should be present. We should ask our microbiologist friends like how many colony forming units are present when they are doing plating. That is very important, and usually they give the report in the same way. There are other investigations which can help us in diagnosing UTI, like doing complete blood count. We will find that there will be leukocytosis and neutrophilia. If it is pyelonephritis, if the kidneys are involved, we may get elevated urea and creatinine. And if there is any structural anomalies, by doing ultrasound KUB, we may get some anomalies like hydronephrosis or hydroureter or thickened urinary bladder or diverticula in the bladder. So they helps a lot, and these are the tests that is important. Now how are we going to treat the cases? Okay, so treatment should be started after obtaining urine culture. That is very important. Just don't give antibiotics first collect the sample properly, urine sample properly, and send it for urine culture. Now if they are neonates and those who have a positive blood culture, parental antibiotics should be given, and it should be given for 10 to 14 days throughout. Parenteral antibiotics is recommended. In case of complicated UTI and infants of less than 3 months, again parenteral antibiotics should be given first. Once the child stabilizes, it can be switched over to oral antibiotics, and the duration is 10 to 14 days. And for the children of more than 3 months, and if there is a simple UTI, we can start with amoxicillin, cotrimoxazole or cephalosporin. Once the culture sensitivity reports arrive, we can modify the antibiotics, and the treatment should be given for a total of 7 to 10 days duration. So how are we going to evaluate the first UTI? So if we have labeled any case as a urinary tract infection, it is very important to do an ultrasonography of kidney, ureter and bladder, USG KUB. If it is abnormal, we have to think of doing invasive procedures like micturating cystourethography and DMSA. If it is normal, and if the child is less than 1 year, we will first do MCU, that is micturating cystourethography, and then followed by DMSA. If suppose the child is in between 1 to 5 years, then first is DMSA. If DMSA is showing some scarring, renal scarring, or if it's showing some problem, we have to do micturating cystourethography. And for those who are more than 5 years, if the USA is normal, like we are not going to do any further workup like DMSA or MCU. So this holds for first UTI. First UTI at 6 years, do USG. USG is normal, we need not do any work. So that is a guideline given by Indian Academy of Pediatrics. Now, kidney, ureter and bladder ultrasonography is of importance. It holds lots of importance to us because we can see a lot of congenital anomalies of kidney disease and urinary tract by the simple procedure of ultrasonography, like hydronephrosis or hydroureteronephrosis or dilated ureter or a thickened urinary bladder or presence of diverticula in the bladder. So like here is, you just see here, like it's a dilated pelvis with LHL system, pelvic LHL system is dilated, which suggestive of some form of either BUR or some form of obstruction in the flow of urine. Now, mixturing cystourethography is a procedure like which we do by injecting urographene or dye from the urethra. MCUG, or it is often called as VCUG, like voiding cystourethography or mixturing cystourethography. It is the same thing, told in different terminologies. It is basically done to see if vesico-ureteric reflex is present or not. Like in about 30 to 40% of the cases we have seen in males, they may be VUR. So like so any UTI, first UTI in less than 1 year, we are like going to do MCUG, and in MCUG we can see a bladder, like if any bladder anomalies like irregularities of bladders are present or not, if the bladder shape of the bladder can be commented properly. Similarly, the degree of reflux can be seen. So here just see some distal portion of the ureter has taken up the dye, so it is grade 1 reflux. Here you can see that like the dye has been refluxed bilaterally up till the pelvis calcium system, but the ureters are not dilated, so this is grade 2 VUR. Here there are some dilatations noted, and due to some pelvic calcium system blunting, and here you can see a grossly dilated ureter and the pelvic calcium system. So this is grade 4, and here you can see the tortuous dilatation of a severe dilatation of the pelvic calcium system as well as ureter, and this is a grade 5 reflux. So it is very important because the management is based upon the degree of reflux, which we will talk later on. Now, if reflux is present, be it a grade 1 or grade 2, in less than 1 year, we are going to do a DMSE. And for 1 to 5 year of children, before doing MCUG, we are going to do a DMSE. So in DMSE, what we can see is like this is a normal kidney, normal DMSE scanning. It is a nuclear scanning. In Nepal, it is available in only one place, in Kathmandu. So we often refer the case for DMSE there. So if there is a scarring, so this is how a scarring, a photopenic defect is seen, and this is suggestive that there is some reflux, and the reflux along with the infection has caused the scarring. So this is how it happens. Now the other question arises is like when to do USG, MCUG or DMSE. So the USG should be done immediately after diagnosis of UTI, anytime after diagnosis of UTI. MCUG is recommended 2 to 3 weeks later, but our practice is like when the case is admitted for complicated UTI, at the time of discharge we do MCUG and then discharge. DMSE scan on the other hand should be done only after 2 to 3 months of treatment. That is a recommendation. And those cases by USG who are showing hydronephrosis, whereas there is no BUR, another test called as DTPA or a diuretic renography should be performed. Another important factor is like, are there any measures to reduce recurrent UTI? So the first thing is perineal hygiene. we should keep a good hygiene. We should give a proper attention to undergarments and foreskins in boys. Basically, the undergarments should be changed frequently, and foreskins in the boys should be washed properly while taking care of the small kids. Cleaning of the perineum should always be done from anterior to posterior. From front, it should be swept to back. Plenty of fluid intake is important, and frequent voiding is important. The child should be taught that they should not hold the urine for a longer time because it is a risk factor of UTI. If constipation is present, it's an independent factor of risk of UTI, so it should be treated, and deworming is advised. If there are toilet trained children with vesicouretic reflux, it is important that they maintain a regular low pressure voiding with complete bladder emptying. For that, double voiding is important. Like once the child voids, you should be advised or you should be asked to void it again. And similarly, timed voiding is also important. Like every 2 to 3 hours, the child should be asked to go for voiding. If there are recurrent breakthrough infections, some recommendations of double prophylaxis with cotrimoxazole and nitrofurantoin has also been there. And there is role of circumcision too. It has been seen that the circumcised male children have very less frequency of UTI. Now about antibiotic prophylaxis. So first, below 1 year of age and those who are awaiting for imaging studies, prophylaxis should be started. In case of vesicouretic reflux of grade 1 and 2, antibiotic prophylaxis should be given until 1 year of age, and antibiotic prophylaxis should be restarted if there is a breakthrough febrile UTI. In case of grade 3 to 5, antibiotic prophylaxis should be given up to 5 years of age, and despite of giving prophylaxis, if there are breakthrough UTI, surgical intervention should be done. Beyond 5 years of age, prophylaxis should be continued if there is history of or clinical features history of bladder bowel dysfunction. In case of febrile UTI, that is frequent febrile UTI, that is 3 or more episodes in a year, and even if the urinary tract is normal by all the imaging investigations we have done, such cases, despite of not having VU or not having any anomalies, should be given antibiotic prophylaxis. Can be given for about a year. Antibiotic prophylaxis should be given as a single oral night dose. There are different antibiotics that is preferred. Cotrimoxazole and nitrofurantoin are not preferred for less than 3 months of child and with G6PD deficiency. Cephalexin is very popular among pediatricians, and the dose is 10 mg per kg per day, and this is a drug of choice in first 3 months of life. Cefadroxil is also another important alternative drugs that can be given as a prophylaxis. So if there is a renal scarring, follow-up should be done. The child should be followed every 6 months, and the growth, blood pressure and proteinuria should be seen. Every year blood levels of urea and creatinine should be done. Ultrasonography should be done every year, and prompt urinary culture should be sent if there is a suspected UTI, and the child later on should be followed twice a year throughout the adulthood. So this is the terminology I want to focus on, that is asymptomatic bacteriuria. Now suppose if we do a urine culture sensitivity, and frequently we are getting a single organism in a sufficient amount of coloniform unit, significant amount of coloniform unit, but there is no symptoms. At that instance we should label as asymptomatic bacteriuria, It happens about 1% of the cases. There is no systemic features, there is no feature sensitive inflammation. The E. coli that is present usually of low virulence. The USG KUB is advised, but usually they are normal, and in such conditions there should not be any antibiotics that should be given. So the message from this particular slide is like, if there is no feature of inflammation, no symptoms, the child is asymptomatic, but only urine culture is positive, mostly it is asymptomatic bacteria and should not be treated with any antibiotics. So the key messages are, UTI in children should not be left unevaluated. It should be properly evaluated with all the modalities I have discussed today. It should be effectively treated to avoid acute and long-term morbidities. Preventive measures including prophylaxis should be taken to prevent recurrence. Long-term follow-up is mandatory in cases with renal scarring. So thank you for today. Thank you for listening to me. Hope you enjoyed today's presentation. Thank you.